Yesterday we left off in our abdominal lectures, and we left off, I think, with this slide. We're going to talk about now intra-abdominal glands and lymph nodes, and then we're going to talk after that a little bit about the gastrointestinal tract, and then after that, just some miscellaneous crap right at the end. So let's go ahead and get started with our intra-abdominal glands and lymph nodes. Also, I'm recording this lecture again, so I will send that to you again, your class rep Adriana, when I get once today it gets rendered and all of that. So I'll send it on later on today. Okay, so with intra-abdominal glands and lymph nodes, we're going to talk most basically about the pancreas, the adrenal glands, and the lymph nodes that we know that live in the abdomen. So starting off with the pancreas is a kind of an ill-defined, friable, lacy-like, tissue organ in the abdomen, and even on a cadaver or surgery-wise on a real dog, it's very ill-defined. It's kind of again, lacy and fluffy looking. It's not like a big, defined organ. And so with ultrasound, it's also kind of difficult to find because it's just, it kind of blends in with the fat and the mesentery around it. So you have to know where the pancreas lives. We kind of reviewed that when we talked about radiographs of the abdomen, but we'll review it again here. In about 50%, I would think, of patients, whether it's a dog or a cat, it's really kind of iffy if you can really define the limits of the pancreas with ultrasound. Again, it just kind of blends in with all the other stuff that's around it. Sometimes you can say, yeah, here's the definitive pancreas that looks very normal, but a lot of times you're looking at it, you're going, here's where the pancreas lives, and it's the pancreatic region. I don't see any abnormalities, but I really don't define a normal pancreas either. You got to remember the right lobe of the pancreas tends to live just medial to the descending duodenum. And the left limb or left lobe of the pancreas lives right along the greater curvature of the stomach, kind of right between where the stomach lives and the colon lives in the abdomen. That's the place to look for the left lobe. And where the right and the left lobe meet, that's some people will refer to that as the body of the pancreas. So this is we haven't talked about GI yet, but that's the section of the small bowel. And right next to it, this little fluffy, ill-defined area right in here looks like a normal looking pancreas. So I wouldn't get too hung up on what a normal pancreas looks like. What you need to know is clinically is what does pancreatitis look like? And that's what we're going to cover here in just a minute. Okay, so if I'm looking at this, that's normal pancreas next to the duodenum. And again, here it kind of is a little bit of a close-up looking view right there. So the pancreas in this animal here, this is kind of an irregularly shaped pancreas. Sometimes it's surrounded by a little hyperechoic mesentery in that area, but that would be kind of a normal looking pancreas. Radiographs on ultrasound, radiographs for looking at pancreatitis are pretty insensitive, if you remember. Next to the stomach and the duodenum, we know that's where the pancreas lives, and so sometimes the duodenum, like we talked about, that sentinel loop, the duodenum becomes mildly gas-filled, secondary to pancreatitis, but there's nothing radiographically specific for pancreatitis. Sonographs is different. On ultrasound, typically, if they get pancreatitis, we're going to see some abnormalities in the region of the pancreas. So what you need to know for pancreatitis, ultrasound is much more sensitive for diagnosing pancreatitis than radiographs are. Obviously, there's now a blood test, the CPLI type tests that look for increased pancreatic enzymes that are pretty specific, are also pretty accurate for looking for pancreatitis, but ultrasound is kind of the other accurate test that if you get both of them that are suggestive of pancreatitis, you can be pretty damn sure that's what's going on. So typically, what do you see with pancreatitis? Well, pancreatitis, we know, is an infection of the pancreas. Why it happens, I'm not sure anybody really knows. We know that some dogs are very predisposed to pancreatitis, and even some cats are predisposed to pancreatitis. And it's one of those conditions that it seems like once you get pancreatitis the first time, you're likely to get it again. And it's very much dietary related. So typically the pancreas is infected, and because of that, it's like any other infection. It tends to draw fluid and blood and maybe a little pus and white blood cells into the pancreas when it's infected. So as it draws in this fluidy stuff, when the pancreas is infected, the pancreas becomes enlarged and kind of more fluffy in appearance. and it becomes more hypoechoic, so darker than normal because it's drawing fluid into it, and fluid tends to show up more darker black grays than otherwise. And so what we look for pancreatitis is an enlarged, irregularly shaped pancreas. And a lot of times it'll be surrounded by hyperechoic, what we term reactive mesentery. So it's normal mesentery around the infected pancreas, and now it's reactive. It's trying to, the body's trying to heal itself. It tries to wall off this nasty infection going on inside the pancreas. And so typically, if I was to ask you, how would you describe the appearance of pancreatitis on an ultrasound, you would want to hit the key things like enlarged, irregular in shape, hypoechoic, surrounded by hyperechoic mesentery. Sometimes you'll see a little fluid in the pancreatic area in the peritoneal space around the pancreas, because if they have longstanding pancreatitis, then that can lead to peritonitis as well, where you have inflammatory cells now leaking into the peritoneal space. You also have to remember that very commonly you'll see secondary things that happen with pancreatitis. Remember, the gallbladder normally contains bile, and through the bile duct, when the gallbladder contracts, it squishes that bile out through the bile duct. Well, the bile duct drains right in the middle of the descending duodenum. So it's kind of in the major duodenal papilla and the minor duodenal papilla, if you remember that from anatomy. Well, that goes right next to where the pancreas is. And so if the pancreas becomes infected and the animal gets pancreatitis, sometimes it can partially occlude or slow down the movement of bile into the duodenum, from the gallbladder. And so sometimes you'll see a dilated bile duct because of that. And sometimes the gallbladder can become really big and huge because of that. And sometimes the pancreas infection will spread up the bile duct and into the gallbladder, and you end up getting also, besides pancreatitis, a cholecystitis, or an infection of the gallbladder itself. Okay, so this is a pretty classic example. And again, here is the pancreas. It's enlarged, it's irregular in shape, it's hypoechoic, and it's surrounded by this ill-defined hyperechoic mesentery around this pancreas. So again, if I didn't know where the probe was, I couldn't tell you what that is, but I do know where the probe was because I did this, okay? So here's another example. This one you get a clue because there's some anatomy next to it. So this is part of the stomach. This is the stomach wall. It's got a little food in the stomach. It looks like right there. So that's stomach. And right next to the stomach, we have this large, irregularly shaped hypoechoic region, again, surrounded by hyperechoic reactive mesentery, a very classic appearance of pancreatitis. You can stick a needle in that, get the cells out, you're going to get degenerative neutrophils and white cells and things like that you're going to see. So evidence of an infection. And again, sometimes the gallbladder gets really big, but do not think that just because you see an enlarged dilated gallbladder, the dog automatically has pancreatitis. We said when we talked about gallbladders, the gallbladder can get big, and then once you eat it, it contracts and squishes out the majority of the bile that's in it. So gallbladder, big dilated gallbladders, you can see with pancreatitis, but you can also see big dilated gallbladders that don't mean anything at all, okay? The other thing sometimes we'll see, because the pancreas lives right next to the duodenum, and we haven't talked about GI yet, but we're going to, this is a piece of the duodenum, the small bowel. This whole thing right in here is the small bowel. And notice it's kind of curlicue. It's kind of corrugated in its appearance. It's not just a straight tube. And sometimes the duodenum, because it sits right next to the pancreas, if the pancreas is sick and infected, then the duodenum doesn't like living right next door to that. And so the duodenum loses its ability to contract, and sometimes it will take on this corrugated-like appearance that you can see pretty commonly in cats that have pancreatitis. Here's another kind of corrugated looking duodenum in that area. And we'll talk about what a normal bowel looks like in a minute, but not uncommon do you see these corrugated duodenums in cats with pancreatitis. Okay, so that's a poor slide. So other things that can happen besides pancreatitis is a pancreatic abscess. And a pancreatic abscess looks like an abscess that we talked about, I think, when we were talking about liver early on in this part of the class. So an abscess in the pancreas is a thick-walled, irregularly shaped structure that has flocculent debris inside of it. You can stick a needle in it and you're going to get pus out of it. Pancreatic neoplasia, the most common one that you're going to see is going to be an insulinoma. And an insulinoma is a very small, usually the size of like a green pea, so 2 to 3 millimeters in diameter, sometimes really small. And because of that, ultrasound is a really poor way in general to diagnose insulinomas or try to find them. So the sensitivity of ultrasound to find insulinomas is piss poor. Sometimes we get if you do a CT exam and give contrast to the animal for the CT, that's probably the best way to find insulinomas. On the other hand, sometimes that doesn't work very well either. They're really hard to diagnose. Okay, here's part of the spleen over here. This is the left limb of the pancreas, and you can see the pancreas is all this other stuff, but it's surrounded by all this ill-defined fluidy-like stuff, which is in itself surrounded by hyperechoic mesentery. So again, you could put a needle in that, you're probably going to get a little bit of pus and white blood cells and degenerative neutrophils and stuff like that. So nasty, ugly-looking pancreas on the left side. Okay, moving on to adrenal glands. Remember, the adrenal glands are some of those organs that, just like the pancreas and just like the lymph nodes that we're going to talk about, the adrenal glands normally you do not see on radiographs. Ultrasound wise, and probably almost every animal, you will be able to find the adrenal glands. When people start learning how to do ultrasounds, and that learning curve, which I said sometimes can be kind of stiff, when you're trying to learn ultrasound, that's always the king that people want to do is, they feel like if I can find the adrenal glands, I'm there. I've learned ultrasound. It's kind of like the last final exam if you can find the adrenal glands. But they're not hard to find. And I think there's two ways that when people learn ultrasound to try to help learn how to find the adrenal glands. One way is needlessly complicated, but unfortunately, that's the way that's taught a lot of times by academicians. The other way is a lot easier, which is what we're going to talk about here in a minute. So most of the time you can find adrenal glands in most animals. And when you do, the adrenal glands, they look like little peanuts. They're very kind of oval in shape to kind of peanut in shape. They're usually well-defined. They're very homogeneous for the most part. And the left adrenal gland is usually easier to find than the right. Just like we said, the right kidney is harder to find than the left kidney. And that's because, again, you have gas in the cecum, typically on the right side of the animal, and that gas makes it difficult to ultrasound the right kidney and the right adrenal gland. So the right kidney and right adrenal gland are harder to find than the left kidney and the left adrenal gland. The size of the adrenal glands is interesting when you look at them. Early on, when they started doing ultrasounds in animals, and specifically in dogs in this case, Cushing's disease, hyperadrenal corticism, is pretty common in dogs. And because of that, they wanted to see if there is any kind of correlation to the size, shape, or margination of the adrenal glands to Cushing's disease. And so there was several studies done years ago, and one of the more common ones they did on beagles. And they found that they looked at normal beagles and they looked at beagles that have Cushing's disease. And they found that when you look at the size and shape of the adrenal glands, the length of the adrenal gland from cranial to caudal, if you measured the length of an adrenal gland, there is no correlation to the length of the adrenal gland to Cushing's disease. However, the width or height of the adrenal gland did correlate to Cushing's disease. And so the bottom line thing with dogs, everybody measures the width of the adrenal glands, and you measure the adrenal gland width where it's the widest. It doesn't matter if it's a cranial pole, mid portion of it, or the caudal pole. Wherever the adrenal gland is the widest, that's where you measure it. Okay. And that paper also showed us that in beagles, that size of a dog, so how big is a beagle? Maybe 25, 30 pounds, something like that. Maybe it's a fat beagle. The adrenal glands in that size dog, a beagleoid kind of dog, should be about 6 millimeters or so or less in thickness. Again, the length does not matter. You can measure the length, but it doesn't correlate to anything. It's the width of the adrenal glands that matter. Okay. So just consider in beagle-sized dogs, 30-pound dogs or so, 6 or 7 millimeters or less is probably within normal limits for the size of an adrenal gland. And they both, right and left sides, should be about the same side. Okay. So now you have to extrapolate up and down the whole dogdom scale. Okay, so if a beagle-sized dog adrenal glands, let's say, have 6 millimeter width or less, then if you're looking at a toy breed, a Chihuahua or something like that, maybe 4 or 5 millimeters. And if you're looking at a Great Dane or a Mastiff, maybe up to a centimeter, 10 millimeters would be okay. So the size and shape of the adrenal glands, is somewhat dependent on the size and shape of the dog. All right, so where do the adrenal glands live? And this is going to be the quick review on how do you find an adrenal gland? Well, we have to remember anatomy, like most things. So this is out of one of the Miller's anatomy. So here's a kidney over here. Okay, there's the right kidney over here. Remember, the right kidney typically sits a little more cranial than the left kidney in most animals. So here's a kidney, here's a kidney here. And then we have two great big blood vessels. So we have the caudal vena cava kind of on the right side, and we have the aorta, which lives on the left side. So those two great big vessels. And remember that aorta and the caudal vena cava, they have these major branches. So here's the renal artery and vein going in here. And the aorta also has the cranial mesenteric artery, and it's got the celiac artery, which y'all all probably remember from anatomy. On either side of the kidneys is where the adrenals live. So this is where the right adrenal would live. And if I had to draw it, I would draw it a little bit differently than this. This is where the left adrenal gland lives. So typically, the adrenal glands in most dogs live adjacent to the cranial pole of each kidney. Okay, just medial to the cranial pole of each kidney. The reason why I would draw the right one a little bit different, the right one tends to hug the caudal vena cava. I mean, it is like wrapped around, like spooning with the caudal vena cava, right? And so it's just right there next to the cava. So it's like not part or attached to the cava, but it's really like the cava, and it's really right next to it. Okay, so there's no real gap most of the time on the right side. And then the other anatomic thing that I do look for is I look for this blood vessel. So there's a little blood vessel from anatomy, you remember, that comes off the cava and the aorta, and that's called the phrenico-abdominal arteries and veins. So if you see this thing that you think might be an adrenal gland, if it's got a little blood vessel that crosses over the waist of it, right in the middle of it, you can bet your bottom dollar that's going to be an adrenal gland. Okay. Lymph nodes, which we're going to talk about next, look just like an adrenal gland, except the lymph node will not have that landmark where you get that crossing vessel, the phrenico-abdominal vessel crossing it. Okay. So whether I mentioned there's two ways to try to find adrenal glands. There's a hard way, that's needlessly hard way to do it, which is taught by a lot of people. And then there's the easy Brian Poteet, this is how we're going to make it easy way. Okay. So the hard way that some people will use, and especially academicians, and I think unfortunately sometimes academicians teach things harder than they really need to be because they're trying to prove themselves that they're smart. And so they make it needlessly complicated to try to explain it, which I think is a mistake. So the way those type people would tell you is they said, well, you have to find the aorta or the caudal vena cava. And then you have once you find the aorta, you have to find where the branch of the celiac artery is. And then you go a little further, and then you find this branch of the cranial mesenteric artery that comes off right in here. And then you find the renal artery, and somewhere between the branch of the renal artery coming off the aorta and where the cranial mesenteric branch, in that area right in there is where the adrenal gland should live. And to me, that is, again, needlessly complicated. Yeah, it's kind of cool to know all that anatomy, but truthfully, I don't remember the names of these things either. But I do remember this vessel. So I think the easier way, other than explaining, find this branch and look in the area between the hook of the cranial mesenteric artery and the renal vein, and that's where you're going to see the adrenal gland. Okay. I think the easy way is I get an ultrasound probe and I find the kidney. Okay. So I just find the kidney. That's easy to find. And then I move my probe. Instead of the kidney being right in the middle of the screen, I move it to where the cranial pole of that kidney is right in the middle of the screen. So now I have my probe kind of centered over this region. And then I start fanning slowly my probe medial. And I might cut into something that is like, oh, crap, I think I see part of maybe an adrenal gland. Okay. If I have my probe straight up and down like this, you can see it's going to cut in first and it's going to cut in just a little part of that adrenal gland to begin with. But I have to recognize that could be a part of the adrenal gland. And then what I have to do is I have to keep cutting further, and then I get more and more convinced. And then to make my adrenal gland really pretty, most adrenal glands are not going to be exactly running north to south. They may be at some angle, the longitudinal axis of that adrenal gland, like this one. So then not only do I have to kind of fan my probe this way, but I have to tweak my probe from going straight up and down to going a little sideways. So I find the adrenal gland that I think is the adrenal gland, and then I tweak my probe a little bit sideways, and boom, there it comes, and it looks like a really pretty nice adrenal gland. Okay. And I do the same damn thing on the right side. Find the right kidney, put the screen right in the middle of the cranial pole of the right kidney. I start fanning immediately until I find something that looks like an adrenal gland. Okay. On either side, if I keep fanning in this area and I get too far and I found a big black pulsating tube over here and a big black non-pulsating tube over here, I don't have to remember the names of those tubes. I just have to think, oh, well, I went too far. Okay. So then I fan again. If you don't find them in that area, that's typically 90% of them, that's where they live. Sometimes they live up more cranial. Sometimes they'll live down here. Okay. Every dog doesn't read the book. Okay. But most of the time, that's where they are. So you can find them by learning vessels, names of branches of vessels, looking in hooks and cracks and everything else, or you can find it by let's find the kidney and go medial to kidney. Okay. That's how I typically find them. So again, the left adrenal gland, I explained how to do it. The left adrenal gland is easy to find. The right adrenal gland is a little harder to find. So here's a picture of the left adrenal gland. Again, it looks kind of like a little hypoechoic peanut right in here. And they measured the length. So the length of that adrenal gland was 2.05 centimeter. The width going this way is 6 millimeters. You want to measure right across the width at the largest, widest part of the adrenal gland, so which is about right here. I wouldn't want to measure here because it's skinnier. So go to the biggest part of the adrenal gland and you measure width. And the width is what matters, not the length. Okay. Here's another adrenal gland. So this is on the right side. So here's the right adrenal gland. Again, it's oval in shape, kind of looks like a little peanut, and you measure the width, and that one measured 5 millimeters. So if that's a beagle-eyed dog, that's perfect. Okay. So that's the measurement of the width of the adrenal gland. That's a crappy slide. Here's a really good one. So this one looks like a peanut. Okay. There's the adrenal gland. And guess what this parallel line is here? You can see this little hyperechoic streaky thing and another streaky thing here and hypoic stuff in the middle. That's the phrenico-abdominal vessels crossing right through the middle of that adrenal gland. Okay. So I know damn well that's an adrenal gland if you see that vessel crossing right in the middle of it. Okay. And again, then you would measure the widest part. Well, this part looks kind of wide. This part looks about the same. So you can measure here or you can measure there. And in this case, it looks like it's 6 millimeters, 0.59 centimeters, which is the same as 6 millimeters. Okay. So what do we see typically with pituitary dependent hyperadrenal corticism? Well, remember, this is the most common kind of Cushing's disease. If you look at all the dogs in the world that have Cushing's disease, about 85% of them are going to have pituitary dependent Cushing's disease. Okay. The other 15% will have adrenal dependent Cushing's disease. With dogs with pituitary dependent Cushing's disease, both of the adrenal glands become enlarged because they're both being stimulated from the hormones coming out of the pituitary gland. And so that causes both adrenal glands to become enlarged. So they both become plump and too wide in appearance. Okay. So what do we see with pituitary? Here's an adrenal gland. We measure the widest part, and this one is 7 millimeters. If this was a Great Dane, that wouldn't bother me. But if this is a Chihuahua, that starts to bother me. A Chihuahua may be 4 or 5 millimeters in thickness is what I'd like to see. Okay. If that's a cat, it bothers me. A cat should be about 4 or 5 millimeters in thickness. Okay. What about this one here? Now it's starting to become kind of plump. So this one here the width measures 1 centimeter. So that's 10 millimeters in width. If that's a beagle, that's too big. Okay. If that's a Great Dane, that's probably okay. So we have to, again, extrapolate the size up and down according to the size of the dog. Okay. Here's another one here. You can see here's an adrenal gland right next to the cava. And again, if I measure that, you can see it's got this kind of a bulbous caudal pole to it. Well, if you measure from this tick mark here down to there is a centimeter. Okay. So this is going to be greater. It's about 1.2, 1.3 centimeter, even if you eyeballed it, right? So that's probably too big, no matter what size dog it is. So the question is when do you call it? And by that, I mean, let's say this is one of these is a beagle and you measure the width of that adrenal gland, and we know in a beagle-sized dog, it should be about 6 millimeters or less. Well, let's say you measure it and measured 7 millimeters. Are you really going to make a big deal about 1 millimeter here or there? And the answer for that, I hope, would be no. Okay. But if it's 20, 30% bigger than it should be, then you start to worry about it. Okay. So again, what you need to know going forward is most of the dogs that have Cushing's disease, the great majority of them will have pituitary dependent Cushing's disease, which typically results in bilateral adrenomegaly, bilaterally enlarged adrenal glands. The other 15% of the dogs that have Cushing's disease will have adrenal dependent Cushing's disease. And with adrenal dependent Cushing's disease, one of the adrenal glands will be enlarged and the other one is either normal or small in size. Okay, so they're not bilaterally enlarged. So with adrenal dependent Cushing's disease, this is an adrenal gland here next to a blood vessel. And that adrenal gland is huge. It's big and rounded. It's not peanut shaped. It's not oval in shape. It's a great big rounded adrenal gland. And if you would go look at the other side will be normal in appearance or really small. Okay, so that's the difference when you're looking for adrenal gland, adrenal gland pituitary versus pituitary dependent Cushing's disease. Okay, you can also get cancer of the adrenal glands, and there's basically two types of cancers. Sonographically, you can't really differentiate which one is which because they look very similar to each other sonographically. So one of them is an adenocarcinoma of the adrenal gland. The other one is called a pheochromocytoma. Both of them are nasty. Both of them are bad tumors to get. They both can invade into the blood vessels around there. So what are the blood vessels that live near the adrenal glands? Well, they can both invade into the caudal vena cava if it's on the right side, or the aorta if it's on the left side. They can invade into the phrenico-abdominal vessels. They can invade into the renal arteries and renal veins. So they like to invade into the blood vessels, and that makes them very tricky to take out surgically. So if you have a dog with an adrenal gland adenocarcinoma or a pheochromocytoma, that's usually a pretty poor prognosis. The pheochromocytomas, sometimes they can come out surgically easier than the adenocarcinomas. But the pheochromocytomas, that's a weird tumor. It's a neuroendocrine tumor, and it makes all these weird hormones like epinephrine-like hormones. And if you start bucking around with it and, with surgery and you're tugging on it and squeezing it and pulling on it, it secretes all these norepinephrine-like hormones into the blood, and the dog's blood pressure starts to race, and then it drops down to nothing and stuff like that. So it's not an easy surgery to take out a pheochromocytoma. Okay, here's an example of a pheo that has invaded into this blood vessel. So this is a fluid filled inside the caudal vena cava. So this right adrenal gland had a tumor and is invading into the caudal vena cava. So all of this stuff inside the caudal vena cava itself is a big thrombus or blood clot, along with tumor tissue from the invading into the cava. And again, surgery, you'd have to go in surgically and take that out of the middle of the caudal vena cava. And again, this is something that as a GP, general practitioner, you would never even try to attempt. This needs to go to a board certified soft tissue surgeon. Okay, so now let's move on to intra-abdominal lymph nodes. And real quickly, this part is easy. You just have to know kind of where they live. Most of the time, again, if it's a well cared for dog that doesn't have parasites, that's on a good diet, most of the time you'll be hard pressed to even find these lymph nodes with ultrasound in a normal animal. Oh, look at that. Okay, so where do they live? Well, the most common group of lymph nodes you're going to see in the abdomen, again, the mesenteric lodes can live anywhere in the middle of the abdomen. And the other group is the sublumbar lymph nodes that you'll see pretty commonly. Okay, so this is an example of a lymph node. Okay, this one's kind of oval in shape. Here's another lymph node in here. These are the sublumbar nodes that kind of live next to this is the termination of the aorta. So that's the aorta and the external iliacs and internal iliacs, and then the median sacral. So that's the aorta and its branches. So right next and guarding and flanking on either side of the branches of the aorta is these lymph nodes. That's where the sublumbar nodes tend to live. So here's what you need to know about lymph nodes. This is another lymph node right in here. And you can see that lymph node looks a lot like an adrenal gland, but it doesn't have a blood vessel that crosses it. Okay. So lymph nodes, here's the deal with lymph nodes. If the lymph nodes are well-defined, slender, and homogeneous, kind of like this guy is, okay, and somewhat cigar shaped, then they're usually reactive nodes and just doing their thing. They act like filters, so they're doing their thing. They can get big if some antigenic stimulus hits them and they're filtering out. They're actually working. They kind of get big for a while, and then once the infection gets under control, they'll shrink back down, and you hardly will see them at all. So that's a kind of an oval shaped lymph node. Let's see, here's another one. So this one's kind of oval in shape. It's a little more worrisome because it's irregular in shape, but it's still pretty homogeneous and well defined. Okay. There's another cigar looking shaped lymph node. Okay, that's sitting in here. So it's that's the tip end of the cigar. And so anyway, there's a cigar, slender, homogeneous, well defined. Cigar shaped nodes typically are reactive nodes. This slide here, we're going to revisit here in a minute when we talk about small bowel. Okay. On the other hand, if the lymph nodes get round, heterogeneous, irregular in shape, sometimes they have mineralized opacities in them. They become irregular. The margins you can't define very well. They start getting more round and heterogeneous in appearance, like this guy here. Okay. That's a not going to be a reactive node. That's going to be something much more sinister, like cancer, like lymphadenopathy that's caused by lymphosarcoma, other types of tumors, malignant histiocytosis, metastatic disease from something else that has now moved into that lymph node or metastasized to that lymph node. So what you need to know about lymph nodes is slender, homogeneous, well-defined cigar-shaped nodes typically represent reactive nodes, and don't worry about them. Okay. On the other hand, if the lymph nodes start to become really big, rounded, heterogeneous, irregular in shape, then you start worrying about there's something brewing in there that's much more serious, like lymphoma. And again, stick a needle in it, it's easy. You can look at the cells under the microscope. Okay, so much for intra-abdominal glands and lymph nodes. Let's go ahead and start GI, the GI tract. Okay, so typically when you're looking at the stomach wall and the small bowel and also the colonic wall, typically the bowel has normal, well-defined layering. Okay, kind of like remember we talked about the urinary bladder wall. Sometimes we said that if the bladder doesn't have a lot of fluid in it, the bladder wall artifactually can look thickened, but you can see 2 or 3 different distinct layers of the bladder wall. Well, in the small bowel and the stomach wall, especially, typically you're going to see about 5 layers, and the bladder, or not the bladder, the stomach wall and the small bowel should be 3 or 4 millimeters thick. Okay, so you can measure the bowel wall on one side should be 3 or 4 millimeters thick, shouldn't be a centimeter thick, and that bowel should have well-defined, distinct layering. Okay, so let's look at that. Here's a stomach. And this stomach is atypical because it's got some fluid in it. So this dog or cat must have just drank a bunch of water. So it's got a bunch of fluid in it and it doesn't have any gas in it. So we can see this layered appearance around it is a normal looking stomach wall. And you can see it's got distinct layers that we're going to talk much more specifically about here in just a second. But if I would measure the thickness of the stomach wall, I would put a caliper right here on that inner white line. And I would put another caliper out to here on this outside white line. And whatever that measures is going to be the thickness of the stomach wall. Okay. This is more typical in appearance. This animal has a stomach bubble, so he's got gas in the stomach. And again, this area right up in here is the stomach wall. The stomach wall we know is probably down in here, but we can't see it because, again, ultrasound will not penetrate through gas and the bubble gets in the way, and that's why we can't see it down here. Okay. But again, if you look at this part of the stomach wall, it's got layering. It's got an outside white line. It's got a little hypoechoic area, a little middle kind of vague white line, and a little hypoechoic layer here. So if I was going to measure the stomach wall from here on this, I would measure a caliper right here, and I put the other side of the caliper over here, and I measure that thickness, which again should be probably maybe 4 millimeters thick. Okay. This is an indentation in the stomach. That's a rugal fold. Okay, so that's just normal rugal fold. You wouldn't want to cheat and measure from the tip of a rugal fold all the way out here. That's cheating. Okay. Again, here's the stomach. The stomach has just a little gas bubble in it. But again, these are prominent rugal folds inside the stomach because there's not much of anything in it. Okay, but again, the layering is well defined around in the stomach wall. Same thing here. Well-defined layering, you would measure from here to here thickness, maybe from here to here thickness, but not from here to the tip of a rugal fold. It's a big rugal fold, another big rugal fold. That would be, again, cheating. That's not the right way to do it. This is near the pylorus. So this is the pyloric region. This pylorus has a little fluid and ingesta. So this is the stomach wall around the pylorus. Okay, small bowel. The duodenum, again, is in a dog, is the only part of the small bowel that's fixed in its location, doesn't move around, and it's usually the part of the small bowel that runs directly cranial to caudal, right next to the right side of the abdominal wall. Okay, it's easy to find. The rest of the small bowel, the jejunum and the ileum, spelled with an E, is scattered throughout the remainder of the abdomen. The ileum, sometimes you can find where the ileum joins the cecum, because the cecum tends to live in the right side of the abdomen. It's this big gas-filled structure, and you can see the ileum going into it. But the jejunum is haphazard, lazy loops scattered throughout the abdomen. Okay, this slide here, I could care less if you know the names of the layers. I'm not going to ask you that, but I do need you to know that a few things about the layering of the bowel wall. Notice that they alternate: hyperechoic, then hypoechoic, hyperechoic, then hypoechoic, then hyperechoic. So bright, dark, bright, dark, bright. Okay, so there's 5, and here's what you need to know. You need to know, write this down because this will be on your test. Number 1, does the bowel wall, the small intestine or the stomach wall, do they have distinct layering? And the answer is yes. Okay. The other thing you need to know is how many layers are there in each bowel wall? Well, there's 5 layers. Okay. And you need to know that they alternate hyperechoic and hypoechoic. All 5 of them alternate, which is kind of cool. Right. And the other thing you need to know, write this down, I'll explain it, is that the inner black line is thick and the outer black line is thin. Okay, everybody get all those things? Okay, having heard no complaints, I will continue on. Okay, so here is a section of duodenum. This is a section of bowel that's running right across the screen. Okay, now the first thing to know is, again, the bowel wall has layering. So the outside margin of the bowel, which is the outside serosal layer, is this nice, well-defined, crisp white line. Okay, that's the outer margin of the bowel loop. Okay, right next to it, there is a thin outside black line, meaning outside towards the outside of the bowel wall. So that's the thin black line right there. That's the muscularis, smooth muscle part of the bowel wall. Okay, and inside that, right here, you will have another less defined hyperechoic thin layer. And then inside of that, you have a thick black layer. Okay, that's the submucosal layer of the bowel. So that's where a lot of the glands and stuff like that, the crypt cells and stuff of the bowel live. Okay, and then just in the middle of the bowel, you have this other white line. Okay, so we have distinct layering, and we have 5 layers. There's 1 out here. There's 2 right there, the thin black line. There's 3 right here, the thin white line. Then you have the inner thick black line, that's 4. And then the 5th one is right in here. Okay. Now, the other thing that you need to keep in mind, and this blows people's minds sometimes, but you'll understand it here in a second, is this middle portion of the bowel right in here, that white line running down the middle of it, that is the lumen of the small bowel. Okay. Normally, none of us run around with food and water and beer and milk or whatever in your bowel. Most of the time, the small bowel is a potential space. Okay, so in this particular case, we had 1 layer of small bowel here on the top, my hand here, and we have another layer of small bowel underneath it. And most of the time, one side just sits right on top of the other side. And so that thin line in the middle is the lumen. When food or fluid comes through, it expands temporarily, lets it go through, and then it comes back down and collapses upon itself. Okay, so this white line is a potent, that's the lumen. That's a potential space that if the dog was actively eating or drinking, that would expand open, stuff would pass through it, and it would shut back down. Okay, so people get this confused. They think this whole area, this black area in here, is the lumen. It's not. It's that white line. Okay, so if this is just a close up of the different layers. So 1, 2, 3, 4, 5. Okay, and so we need to know, number 1, there is layers. Number 2, there's 5 layers. They alternate hyperechoic to hypoechoic, and the inner black layer is thick while the outer black layer is thin. Same thing on this side of the bowel. Okay, here's the lumen. This is the other side of the bowel wall. Okay, the inner black layer is thick. the outer black layer is thin. Okay. If I wanted to measure, and this, you need to know this too. If I was going to measure bowel wall thickness, I would go from the outside serosal margin of the bowel here to the lumen. So that is the bowel wall thickness. If I asked you to measure bowel wall diameter, that's different. Bowel wall diameter is from one side of the bowel to the other side of the bowel. Okay. So there's a difference between bowel wall thickness, measuring one bowel wall, versus the diameter of the loop of that bowel. Okay. So again, here's another section of small bowel. There's bowel here. It's kind of running longitudinally across the film. There's another section of bowel. Now this one's kind of in tangent. So it's kind of coming in and out of this picture, this one slice of ultrasound, right? And so, but again, same thing. Here's the bowel, the outside black line's thin, inside black line's thick. It's got that's the lumen, a little bit of gas in it. Same thing here, even though we're kind of catching it end on. Outside black line's thin, inside black line's thick, that's the lumen. So bowel wall thickness would be from here to out here, okay? Bowel wall thickness on this side would be from here to out here, okay? Now this section of bowel, now this one has a little bit of food traveling through it. So instead of a thin white line in the middle where one side of the bowel is sitting right on top of the other side of the bowel, now it's expanded a little bit while food goes through it. So all of this stuff in here is a little bit of ingesta that is expanded the lumen up a little bit. And that ingesta, if you watched in real time, you'd actually be able to see it go from this one direction to the other direction, okay, as it passes through the bowel with normal peristaltic motion. Okay, this section of bowel has a lot of food going through it. And again, if you give it a minute, you know, or a second, or a couple of seconds, that will usually travel through it, move on, it'll collapse back upon itself. Okay, so that's another part of the small bowel where there's food traveling through it. Okay, another section of small bowel. So again, there's a little bit of probably gas in this area, and up here it's very well defined. Okay, but again, bowel wall layering is well defined, 5 layers, inside black layer is thick. Okay, this one again, here's what we've been looking at, where this side's collapsed upon the other side. So it's this little thin white line, which represents the lumen. Here, there's a little bit of gas, that's a little gas in there, and a little bit of food that's traveling through it. So it opens up that potential space of the lumen. Once it travels through, it's going to collapse down, and now that part of the bowel will look just like this, with just a little thin wall where one side's collapsed upon the other. Okay. So what do we see with ultrasound when we're talking about GI disease? And again, I think it's very important to consider that with ultrasound, with radiographs, and the typical dog that's going to come in at 5 o'clock on a Friday and he's vomiting, the best thing to do is radiographs first. That's going to be your go-to. Okay, do radiographs first to try to decide, do I go to surgery or do I not go to surgery? Okay, and again, if you can't decide definitively on the radiographs, then your next step would be, let's ultrasound the dog and see if the ultrasound can help me get off the fence one way or the other. Before ultrasound came about, we had to do upper GI series, which is a pain in the ass. Okay, so now at least we can do ultrasounds much quicker, much non-invasive, and a lot better, a lot more specific. So what do we look for abnormalities? Well, again, we come up with this term called ileus. Okay, and there's 2 kinds of ileus, just like we reviewed. Ileus itself just means there's something wrong with the bowel, it ain't working right. That's what ileus means. Okay, but there's 2 kinds. There's either a functional or paralytic ileus, and these are the kinds that's due to an infection, a viral infection, parvovirus. The dog ate something funny, but it's not obstructing him. Okay, functional or paralytic ileus you treat medically. Fluids, gastroprotectants, antibiotics, give it time. Usually they get better. Okay, a mechanical ileus or an obstructive ileus is an obstruction that they ate something, and most likely it's not going to get through the small bowel, and you're going to have to do surgery to take it out. Okay, so you try to decide which one it is, and films again will help you. And then there's some other things that we'll talk about here too. So again, if you look at this animal, here's part of the spleen. Okay, and then there's a section of bowel here. That's the bowel wall on this side of that bowel. Okay, and again, 5 distinct layers. Right in there, everything looks good. 5 layers over here. That's the other side of the bowel wall. But look at the luminal diameter compared to the thickness of the bowel wall. It's hugely dilated with something inside the lumen that's expanding it out. Okay, and in real time, if you would watch this stuff, this kind of fluidy stuff inside the bowel, it wouldn't be moving in just one direction like normal peristalsis. Okay, it would just kind of be going to and fro, just kind of back and forth and never does go anywhere. And if you would follow that bowel loop down, sometimes you're going to actually find a rock or a ball or whatever the dog ate that's causing the obstruction. Okay. And you can kind of follow it down and try to find the obstruction itself. Again, look, here's bowel wall over here. It's nice and thin and smooth with nice layering. Over here, there's the other side of the bowel wall, but the lumen is tremendously dilated with whatever is sitting inside that bowel loop. So that would go along with a mechanical obstruction. This is an intussusception. And again, ultrasound is great for diagnosing intussusceptions. You can't miss it. There's not much else that looks like it. Okay. So here is you can see there's a bowel loop right in here. And this hyperechoic mesentery is surrounding that bowel loop. Well, this whole thing is surrounded by another bowel loop. Okay. And that's classic intussusception. Again, there's nothing else really looks like that. And the most common spot for intussusceptions always is going to be in the ileocecal area. That tends to do this more common than any other part of the bowel. Okay, this animal had a linear form body. So instead of a bowel loop that looks like this going straight across the screen, with a linear form body, you end up with a bowel that is a roller coaster ride. So this is a bowel loop. So it's kind of coming in here. There's the outside of it. It's coming way down here. It's coming up in here. It's coming down in here. So that bowel loop becomes roller coaster. It's a plicated section of bowel. It's like the bottom of your curtain. Okay, it's plicated in its appearance, and that's because there's something, a string or a thread or dental floss or something in the lumen of the bowel that the bowel is now literally climbing up. And given time, as this bowel has peristalsis and that string in the middle of it, the string will actually saw through the bowel and perforate the bowel, which is a bad thing, obviously. Okay, the other thing we can talk about when we talk about infiltrative disease involving the bowel wall itself is inflammatory bowel disease. This is a normal section on the right of small bowel. Again, well-defined layering, outside black line is thin, inside black layer is thick. Okay, this is a kitty cat that has inflammatory bowel disease. This is that same slide I showed you a while ago with the cigar-looking lymph node, so probably a reactive node. Well, here's 3 bowel loops sitting right on top of each other, 1, 2, and 3. Okay, if I look at all of those bowel loops, let's just look at this one here, this middle one in here. So this white line going down the middle of that bowel loop is the lumen. That corresponds to here. Okay, and then I have on either side of it, I kind of have a thick black line. So there's the thick black line, the inner layer. Okay, but look at the outside black line. Now it's as thick as the inside. Okay, this another bowel loop down in here. So here's the inside thick black line, but now the outside black line is as thick as the inside. Okay, so you lose the thin outside black line. It becomes as thick as the inside black line. Okay, and that's typical for cats and dogs with inflammatory bowel disease. The key is, though, is you have to recognize the thickening of the outside black line is abnormal. However, the definition of the layers is still intact. Okay, we can still see the edges of these layers. Okay, the thick outside black line is too thick, but the definition, the layering is still intact, still well defined. Okay, so that's a typical inflammatory bowel disease of cat. They get thickened outside black muscularis layer of their small bowel, and that most of them will have some reactive lymph nodes. Typical IBD in a cat. Okay, another section of bowel. Here's the inside black layer here. Here's the outside black layer. It's as thick as the inside black layer. Okay, that's again IBD in a cat. Okay, let's take a break. Let's come back in 10 minutes, and we're gonna finish up our abdominal lecture. Okay, see you in 10.